Okay, guys, this is CT 4071, lesson 3. We are talking about the genitourinary system, or GU system. CT is the primary imaging modality for the evaluation of urinary tract, which consists of the kidneys, the ureters, and the bladder. The kidneys are enveloped and supported by a sheath of connective tissue called the Garrota fascia. Supported because there are some tumors that are just located in that fascia, and we'll talk about those in a second. The renal parenchyma consists of the internal medulla surrounded by the renal cortex, and then the renal pelvis contains the minor and the major calyces, which lead into the ureters. Urothelium is the epithelial lining of the urinary tract. And some common indications for CT of the urinary tract include the identification of urinary calculi, or lithiasis, as it's called. These are stones, renal stones, or ureteral stones. Another indication is evaluation for tumors or infection. And then also we want to visualize and assess the renal vasculature. So we're looking at some renal anatomy here. The cortex is here, and here is the medulla, and these renal pyramids. The medulla is in the shape of these renal pyramids. You'll see those on contrasted studies of the kidney show up. And the kidney is connected through this connection to the minor calyx here, and these are the calyces. This area here, this tan area, is where the urine collects, and then it goes through into the renal pelvis and down the ureter into the bladder, out through the urethra. So this is called the renal capsule that surrounds this whole kidney. And what's important for you to know is that the renal, the major and the minor calyces, or the renal pelvis, which is in here. That make up the renal pelvis, which is here, because this is a popular site. If a stone is in the ureter and blocks up, you're going to have hydronephrosis, or this area, this renal pelvis, is going to swell. It's going to be full of fluid. It's backed up because it's constantly being secreted into the renal pelvis, but it can't go anywhere because the stone is obstructing it. So anyway, that's the anatomy of the kidney. Here's the urinary, the ureters that flow down into the bladder, of course, on both sides, the kidney, and then you see the adrenal gland sitting on top of it that we just got through talking about. You have a ureter, the opening of the ureter where it comes into the bladder, and then, of course, the bladder neck and empties into the urethra. Imaging plays an essential role in the diagnosis and initial management of urolithiasis, or kidney stones. The imaging methods used have undergone considerable evolution in recent years. One major advance is the use of non-contrast helical computed tomography, or NCHCT, in patients who are suspected of having renal colic. Here we review various aspects of the formation diagnosis. And I'm sorry, I didn't mean to read that part. I want to skip down to the terms. The terms that we use, and you'll hear in scanning for renal stones, are kidney stones, renal stones, and renal calculi, nephrolithiasis, and urolithiasis. Those are all used interchangeably now. So you may hear any of those, and for most of us, or most of medical field, a lot of us, those terms, renal stone or kidney stone, regardless of where it's located, is a kidney stone. But there are actually locations where they're called by where they're located. So anyway, we'll talk about that. Renal calculi in the urinary tract and can cause extreme pain. I'm sorry, let me back up a little bit. When I was telling you that they're used to describe the kidney stones, or the gravel-like deposits, and they can appear in any part of the urinary system from the kidney to the bladder. So for those of us that we need to know, we can use the terms specifically to where they're related. So if you have a stone that's located in the kidney, and then you would call it a renal calculi. But if it's in the ureter, you're going to call it a ureterolithiasis or a ureter stone. So that's a matter of semantics among most patients, especially, but among most in the medical field. But when we're discussing them with the physicians, and we need to be able to say, yeah, it's a ureterolithiasis that's located in the ureter, or it's a renal calculi located in the kidney. So that aside, the renal calculi in the urinary tract can cause extreme pain, and that table in Romans is 21, table 21:8, explains where, in relation to the pain, the calculi are most likely located along the GU system. So if your patient comes in, if they're having just vague pain and hematuria, the stone's most likely going to be located in the kidney. And if it's flank pain or upper abdominal pain, it's going to be the proximal ureter. And then if you have, if it's in the distal ureter, there's going to be dysuria, urinary frequency, anterior abdomen pain, and flank pain. Not flank pain but flank pain. Most commonly, that's what you'll get the diagnosis. Left or right flank pain. Sometimes they'll tell you it feels like it's going into the groin area as well. So non-contrast CT of the abdomen and pelvis was first described in 1995, and since that time it's gained widespread acceptance among radiologists, urologists, and emergency room physicians, and it's become the standard technique for evaluating for suspected renal colic and calculi. The advantage is that it, compared with all the other techniques, is its diagnostic accuracy. More than 99% of the stones, including those that are radiolucent on plain film radiography, will be seen on the non-contrast helical scans. So throughout your career, you'll be doing many of these, which they're quick and easy and fast, and so really a lot of us as CT techs don't mind them. The scan parameters for CT abdomen pelvis for kidney stones are thin sections from 2.5 to 5 millimeter from above the kidneys through the base of the bladder. Most protocols don't include the diaphragm as we do in a routine CT abdomen pelvis. Now you're going to see two different versions here. And DiMaio says 3 to 5 millimeter sections are what's used. Romans says 2.5 to 3. Romans is closer to what the standard is and is becoming now with the scanners that we use. We're going to scan at 2.5. We're actually going to scan at 5 and rebuild at 2.5. So that's the dose-saving way to do this. But we're going to stick with Romans and say the standard is 2.5 to 3 millimeter sections is what you need through the kidneys, from above the kidneys through the base of the bladder. It's going to be non-contrast. Some protocols can have the patient drink water to flush out the hyperdensities in the renal pelvis. And if there's a question of a UVJ stone versus a phlebolith, you can scan the patient prone, and the phlebolith will not fall to the anterior abdomen as the patient's prone. The stone will, because the ureters will kind of hang, not really hang, suspend, but they'll move in position. So, but a phlebolith is not going to move. The vein is not loosely flowing around. I mean, the vein is not loosely. It's tightly compacted and connected in a sheath, and it's not going to float. It's not going to fall to the dependent side. So that's how you tell the difference. But if there is a question and it still is not working, you can use IV contrast, and that'll distinguish the ureter from the phleboliths. As some people use scan, there'll be tons of phleboliths down there, and you can't tell what's a stone or what's not. All right, so here's an example of a renal calculi. It's located inside the kidney in the calyces. All right, here's another one, axial slice of it. This one's enhanced with contrast, as you can see, so it showed up there. Here's some ureteral stone. Actually, this one's in the renal pelvis or calculus. Calyx. It shows up here on plane on the scalp film. You can kind of see it. It's how dense it is. And then this one shows up down here on this scalp, but it's at the UV junction there in the ureter, in the ureters. Sorry, in the ureter. Cystic renal masses are common. You're going to see them a lot. They're usually benign, and they may be identified before IV contrast. They include simple cysts, which will be smooth and they'll be round-walled, and they'll have a Hounsfield unit of less than 20. There are some hyperdense cysts that are complicated cystic masses. They can be between 25 and 90 Hounsfield units. They can be caused by infection or hemorrhage. And then you can have polycystic kidney disease, which is a genetic disorder we'll talk about and see in pathology part of this, of the pathology course. But it's a genetic disorder, and there are numerous cysts that just completely fill the kidney. You can have a parapelvic cyst, which is in the renal pelvis. It occurs within the renal pelvis, and it can mimic a hydronephrosis. And delayed imaging with IV contrast will distinguish it from hydronephrosis because it'll either fill with contrast or it won't, so you'll be able to see the difference. Hydronephrosis or hydroureter is a blockage above the level of the bladder that causes unilateral dilatation of the ureter, hydroureter, and pelvic-calyceal system. And you can have causes hydronephrosis. We'll talk about that in just a sec, or you'll see an image of it. So, looking at these renal cysts, here is a cortical cyst. It's in that region we talked about, the garrote fascia. There's another here in the cortical region. And these are called medullary cysts. They're in the medullary part. I'll show you. In the medulla in here. Okay. And the cortex is right in here. That's where those two cysts were located. All right. Number two are complicated cysts. They have some blood in them and denser tissue and stuff in there. So you're not, and you can tell here's a highlighted part of the kidney, and then there's the big cyst there. So it's a complicated cyst. And number three is a example of polycystic kidney disease, and you can see how all just numerous cysts all in both kidneys. And then here is a parapelvic cyst. This is in the pelvis, renal pelvis. Here's the the ureter's filled with contrast here, trying to go around that big old cyst, and it's distinguishable from hydronephrosis because the contrast is filling the ureter and going through. So these are parapelvic cysts. They're not hydronephrosis, because hydronephrosis can look like this, and they do. So here you go. This is the difference. There's the ureter going around, or that's not the ureter, but either way, this is this is part of the ureter here, full of fluid backed up from the stone, and this is basically what happens here. You have the collecting system that just is dilated because there is a stricture down here that's causing either from the stone or something else that's causing the hydroureter, so it's filling up with fluid. And then the hydronephrosis, where the collecting system of the kidney is filling up. So it's two different aspects of it, the hydroureter and the hydronephrosis. Of course, ureter is the hydroureter, and then the hydronephrosis is the renal portion. And this is a CT urogram, a MIP. We'll talk about that in a second too. But this one shows hydronephrosis, where the collecting system is backed up, where the contrast is filling it and swelling, and then the ureters are coming down here. After administration of contrast, a renal cyst should not enhance, but if it does, it can be a malignant tumor. And renal malignant tumors include angiomyolipomas, which is most common. It's a benign mass of blood, muscle, and fat, and it's characterized by a Hounsfield unit of less than -10 Hounsfield units. The malignant tumors, actually angiomyolipoma is not malignant, but it's a mass. The malignant tumors consist of renal cell carcinoma, which is the most common primary renal cancer. It's characterized by a marked contrast enhancement of greater than 20 to 25 Hounsfield units. Then you have transitional cell carcinoma. It originates in the urothelium. Most arise in the bladder, and on pre-contrast, they usually appear as hypodense lesions in the renal collecting system with a Hounsfield unit of less than 40. But they significantly enhance after contrast. And then, of course, you can have METs or metastasis from lung, colon, and breast are the primaries that are most commonly are the most common METs that end up in the renals. As with other organs of the body, the kidneys undergo different phases of contrast enhancement too, and those include the corticomedullary phase, which is the late arterial, and that's 30 to 40 seconds. The optimal enhancement of the renal cortex and the renal veins occurs during that time. The nephrographic phase is the 70 to 90 seconds, and that's the cortex and the medulla are in equilibrium, and this allows the best visualization of parenchymal lesions within the within the kidney. And then the excretory phase is 3+ minutes, and that's when the collecting system is filled. And it best demonstrates the filling defects and lesions involving the urothelium and transitional cell carcinoma. And you also have bladder enhancement during that time. Just something else to mention, you can have ureteral duplication, and that's a dual collecting system, and that's the most common abnormality among the kidneys and the ureter. You'll see that every now and then. A special study that's becoming popular with a lot of the nephrologists and those guys is the CT urogram or the CT IVP. And it's a comprehensive multiphasic evaluation of the urinary tract. The protocols basically consist of a non-contrast scan of the urinary tract, and then a post-contrast scan of the abdomen pelvis. Then thin section delays, excretory phase of the excretory phase of the urinary tract, and these thin section delays they can go on for 5 to 10 and on and on. So anyway, like an IVP does, and a lot of urologists have different protocols that they want you to do, and so you have to check with the referring physicians usually, or you may already have that protocol at your facility, but they can last for a while. You can scan the patient quite a few times. So anyway, the last thing you'll do is some coronal MIPS and volume rendered 3D images of it. So you have these MIPS, and then like the ones I showed you earlier with the hydronephrosis here, you'll turn all of those in, and really pretty studies, and she can show the function of the kidney as well over time. So that is our look at the genitourinary system. The next time we're going to talk about the GI system.